Welcome, everyone, to the National Hypertension Control Roundtable Fireside Chat on faith-based initiatives in improving hypertension control. I am Jenny Bogard and the Executive Director of the Roundtable, and I am so incredibly excited to be joined today by this esteemed group of colleagues to talk about the amazing work that they are all doing in their communities. So with that, I am going to pass it over to our very own steering committee member, Dr. Yvonne Commodore-Mensah, who will be moderating today's chat. Yvonne, it's all yours.
Thank you so much, Jenny. Good afternoon, everyone. Thank you for joining us for today's Fireside Chat that is titled Faith-Based Initiatives for Improving Hypertension Control. I'm so honored to moderate our conversation today. I'm Yvonne Commodore-Mensah. I'm an associate professor and cardiovascular nurse epidemiologist at the Johns Hopkins School of Nursing and the Bloomberg School of Public Health. I'm also a member of the steering committee of the National Hypertension Control Roundtable. And the NHCR is a coalition of public, private, and nonprofit organizations that's dedicated to eliminating disparities in hypertension control through dialogue, partnership, evidence, and innovation. So the NHCR, or the National Hypertension Control Roundtable, prioritizes supporting people in controlling their blood pressure wherever they live, learn, work, play, and pray. And today we're going to be focusing our conversation on where people pray. So I'll provide a quick framing for our conversation today, and I'll introduce our esteemed panelists who are here with us today. And for our audience, we want you to be part of our conversation today. So please put your comments, your questions in the chat, and please do join us at the fireside. So why are we here today? So we know that 1 in 2 adults in the US have hypertension, and even more troubling is the fact that among those who are diagnosed with hypertension, only 1 in 4 who have hypertension have their condition controlled. We also know that there are persistent racial and ethnic disparities in hypertension control in the US. For instance, Black people are more likely to be diagnosed with hypertension and are less likely to have their condition under control. And the reasons for these disparities are deeply rooted in structural factors and differences in social determinants. We also know that most of the excess deaths from CVD mortality in Black adults is attributable to the higher prevalence of uncontrolled hypertension. But the good news is that there are proven and best practices and evidence-based strategies and models of care to control blood pressure. The challenge is, how do we take what we know and implement these strategies in different settings? So here with us today are 3 experts who will share their insights on this very important topic. I'll start by introducing our first panelist, Dr. LaPrincess Brewer. Dr. Brewer is a cardiologist and assistant professor of medicine within the Mayo Clinic Department of Cardiovascular Medicine in Rochester, Minnesota. Her primary research focus is developing strategies to reduce and ultimately eliminate cardiovascular health disparities in racial and ethnic minority populations and in underserved communities through health promotion and community-based participatory research. And Dr. Brewer is leading the FATE trial, and you'll hear all about it shortly. And FATE stands for Fostering African-American Improvement in Total Health, which includes community co-designed cardiovascular health promotion intervention in partnership with African-American churches. Welcome, Dr. Brewer. Thank you for being here. Our second panelist is Dr. Keith Ferdinand. Dr. Ferdinand is a professor of medicine and the Gerald S. Berenson Endowed Chair in Preventative Cardiology at Tulane University School of Medicine. He's a native of New Orleans, lower 9th district. Did I get that right? He's conducted numerous trials in hypertension, cardiometabolic risk. He's also recognized as a living legend. In addition to his clinical work, he's participated in numerous clinical educational activities and communities locally and nationally. And he's laser focused on also eliminating disparities in cardiovascular health. And to add to that, Dr. Ferdinand is also president of the Healthy Heart Community Prevention Project. And you'll also hear more about that project. And he is co-leading the CHERISH study with Dr. Jiang He. And this study is focused on also addressing cardiovascular disease prevention in African-American communities in New Orleans. So thank you so much for joining us, Dr. Ferdinand. And last, we have Dr. Bishop Abraham Shanklin Jr. So Dr. Bishop Shanklin is the founder and president of the Center of Transformation in West Anne Arundel County, Maryland. The Center of Transformation is the parent organization to New Life Fellowship International Ministries Church, New Life Academy, New Momentum Health and Wellness, and the New Image Development. And they are serving the Anne Arundel County and Baltimore counties, and they reach over 200 families weekly. And Dr. Bishop Shanklin is also a clinical Christian counselor and a licensed pastoral counselor. He's a member of the Greater Maryland and Baltimore American Heart Association, and he has actively served his community for more than 4 decades. So welcome, Bishop Shanklin. Okay, so let's dive right into our conversation today. And for those of you who are joining us, welcome. We look forward to hearing from you. Please put your comments and questions in the chat. So I'll throw this question first to our panelists. So we know that the goal of the roundtable is to improve blood pressure control rates nationally and get to 80% by 2025, which is only, 2 years away. So from your perspective, do you think that engaging faith-based organizations will help us to achieve this goal? So we'll start with Dr. Brewer.
Yes, first of all, I just want to thank you so much for inviting me to be amongst such esteemed colleagues to present today, and also to the National Hypertension Control Roundtable for even having this topic as a focus, as it's extremely important to our communities and to those that we serve. So to answer your question, it is extremely important that we engage with the African-American faith community, as really it's the centerpiece and has always been of the African-American community, and is a stronghold in political, social, religious influence, within the community. And I find that our faith leaders are the shepherds and the champions also for health promotion within their congregations. And not only is the Black church a place of salvation and refuge, it's also a place that people seek out social services, health services. Many of the Black churches also have nurses' guilds, is what we call them, to help to screen for hypertension, blood pressure, and also to encourage those to seek care outside of the church to make sure that their hypertension is under control once it is screened. So I think it's extremely important that we engage with the faith community in order for us to reach those really, I would say, I'm not going to say far-fetched because we can reach them, but those goals by 2025.
Great, thank you so much. Dr. Ferdinand?
Yes, I agree. And I thank you also for this opportunity to participate in this esteemed panel. If you look at life and death in the United States, the white-Black mortality gap, the white-Black death gap has been persistent for decades, driven mainly by cardiovascular disease. We hear a lot about drugs and drive-by shooting. That's sensational. But if you look at the main reason people die, it's from heart disease and stroke. And these disparities have been persistent. It just never made sense to me that we could control hypertension with the magic 15-minute doctor visit 2 to 3 times a year, where a person lives with this condition 24/7. So I'm pleased here in New Orleans to be a co-investigator in a major NHLBI-sponsored trial called CHERISH. It's an acronym, it's an abbreviation. It stands for Church-Based Health Initiatives to Eliminate Racial Inequities in Cardiovascular Health. And part of CHERISH, we have a nested trial called Blessed, in which we specifically are going to use community health workers, Those are persons who may not even have an advanced degree at all. And nurse practitioners, those are clinicians who may or may not have prescriptive authority, but are able to help patients navigate our tortured, twisted, complex healthcare delivery system. It just makes sense to me, looking at the fact that 80% of the burden of chronic diseases are due to what you described, Yvonne, as the social determinants of health, where people work, live, play, and pray. It just doesn't make sense to me that we wait for patients to show up in the emergency room, ICUs, or even in clinics and continue to think that doing this over and over is going to change the arc of these disparities. So yes, I think that's the way to go.
Great, thank you so much, Dr. Ferdinand. So Dr. Shanklin, I would love to hear from you. Do you think engaging with faith-based organizations like yours may help us to achieve the 80% on hypertension goal?
Yes, absolutely. Good afternoon to all of the incredible panelists that I get to be in a relationship with in this space. And thank you, Dr. Yvonne, for sort of moderating this. And as one who works within the faith community directly, as a long-term pastor of 30 years, I am 100% in agreement with both of our panelists about how imperative it is that we engage the faith community for particularly two reasons. And for those who are continuing to come and facilitate and participate in this, one, because the faith community is a ready community, and two, the faith community is an available community. And so because it's ready and available, you have by default an automatic audience of people that you can disseminate the message. I mean, after all, as has been already alluded to, the faith community has always been this central figure in a community where we disseminated everything, whether it's social services, whether it's the message. In our community, you have the wherewithal to get information out. And so we have our particular ministry has been on the foreground and actively engaging, such as having Sundays blood pressure checks and blood pressure loaning systems where we allow people to sign out blood pressure so that they can do some self-monitoring and things. So we've been doing some incredible things that have helped to shift the narrative and literally to contribute to our own well-being. Because at the end of the day, how do we get other people to partner with us about our cardiovascular health, our hypertension and such, if we ourselves are not actively engaged? So absolutely, the faith community is a ready and an available community.
Great. I love what you just said about being ready and available. And in a few minutes, we'll talk about how to actually thoughtfully engage with faith communities. So Bishop Shanklin, you have a personal story that I've had the pleasure of hearing. Can you share with us sort of why this is so personal to you?
Yeah, so the Cliff Note version of all of this is growing up historically in the Black and brown and beige community. We didn't do a lot of tracking of health. So there was no written history of my family health. So I never knew what troubled my father, what troubled my mother, what troubled my paternal or maternal grandparents. And so we never had anything documented. And fast forward, I joined the military, got in the military, and just literally, trying to live my life, do the best I can, withstand in the best of health. And in 2005, I ended up at a very young age, at 40 years old, having a heart attack. And I had a heart attack because I wasn't aware of the issues in my family that were problematic, directly related to heart disease, hypertension, some of the other things that were going on. I solved them as a kid, but didn't properly interpret them with respect to my parents. And had this heart attack in 2005, had what the doctor described as a widowmaker, and literally could have left my wife and my children without a husband and a father. And so it was an eye-opening experience for me, knowing that I had this blockage, I had all this going, and then to be diagnosed with this degenerative, disease, and how that lack of information, that I believe, had I had the information early on, had we had the partnerships and the coaching, could have done some preventive things in this matter, but there was nothing preventive and nothing passed down. So I, having survived a heart attack, having 2 stents, put in, and then a journey of health and wellness ever since that moment. You can just best believe I'm hypertension's worst nightmare. I'm cardiovascular disease worst nightmare. I'm in the community making people aware that this something right here, nothing you can play with.
Thank you, Dr. Shanklin. I'm going to step in momentarily because, of course, with these live events, we can never determine and predict everything. And there's a fire drill going on with Dr. Commodore-Mensah's office. So we're hopeful that it is just a drill. But I will take it from here while she just confirms that she doesn't actually have to evacuate. So never a dull moment in this virtual space. Dr. Shanklin, thank you so much for sharing that story. And to follow up, you know, I'm sure it was an incredibly scary and also uncertain time when you went through that health crisis. You know, when did you decide, you know, after you were able to come out through the other end, that you really had this wonderful platform, that you were on this platform that you could really truly connect with the people that you serve in the position that you are in within your church? When did you make that connection?
And that's a great question. And I think I made that connection because in this work, I've always been the, in air quotes, the reluctant leader. So, you know, essentially called, stepped up and fulfilling it, but always the reluctant leader. I was always hesitant at the idea of having to model, you know, certain actions, things like that. But after that event, I realized that I needed to get over myself and realize that if I don't begin to champion what is important, particularly around this kind of health, then how would the other people also participate in being proactive with their health? So I got over being the reluctant leader and stepped up and was like, okay, here's what y'all need to know. If this happened to me, it can happen to you. So I don't care if you don't like it, you don't like the sermon, you're gonna get it. So in my sermons and my messages, I was preaching high blood pressure, I would have a heart, I would just do all those things, just really recognizing the influence that we have in our community and how important it is to spread the word, how much they value the voice of leadership in the community. So I think that certainly was an epiphany for me that, you know, if people are going to take this serious, then sometimes the most path forward is somebody who's been through the experience, who lived to tell the story. And because I lived to tell the story, all of a sudden now I've leveraged that moment as momentum to get out here and really challenge people. And, you know, through our programs and things since subsequently through the years, we have changed people's lives.
And what has been the initial response and the response now with the people in your community, within your church? I mean, you are a trusted individual, and we talk a lot about, you know, not everybody has that access point to their primary care provider or even a cardiologist. When you first started sharing this message and sharing your story, encouraging your congregation to really track and understand what blood pressure even meant, what was the initial reaction? Did you have any resistance, or because you're such a trusted figure in your community, did they follow your lead immediately?
Yeah, and there was some apprehension simply because people by and large are apprehensive about going to the doctor, no matter what the skin color is. People just don't trust doctors and the things that they were putting forward. So I literally got an opportunity to be ambassador for some of my friends or some of the best physicians in the field who can contribute and bring along, you know, the information that's necessary for people to make right health choices for themselves. So there was a apprehension, a pushback, because a long-standing historical idea that you can't trust doctors, no matter, you know, they're in the pockets of pharmaceutical companies, they're in the pockets of this and such. And so by creating this bridge of trust, you know, we got more and more people to open up and say, listen, that's your doctor, right? And so you need to go, you know, advocate for your own health, ask these questions, dig in, such. You don't have to just accept what you hear. So yeah, there was some great pushback in the beginning, but we've been able to, over the years, really build that sort of competent trust and that bridge towards some great physicians like Dr. Keith here and Dr. LaPrincess. It's just been a wonderful opportunity, and yeah, we've been able to accomplish that.
So I'm going to ask one more question and pass it back over to Yvonne. So thankfully it was just a drill. We're so happy you're safe. Doctors Ferdinand and Brewer, what's your response to that, based what Dr. Shanklin just said, that about the resistance, and any type of advice or for the work that you've all done in your projects, how you're able to overcome that resistance?
I can start, and I must say that when I first reached out to the Black churches here in Rochester, Minnesota, there was that apprehension of me and reluctance to partner. And I really didn't understand it. And just as the bishop said, you know, it was this kind of this longstanding mistrust that had built up over time. It really had nothing to do with me personally, but it was something that I needed to recognize. And it was more so that, you know, I was coming into the community, I had my suit on, had my PowerPoint slides, you know, standing up, towering over them and not meeting them where they were and looking them straight in the eye and really building that trust and relationships. So they really initially were not wanting to or willing to partner with me. So I had to really take a step back to understand, you know, what that was all about and why me, why was the, you know, kind of resistance towards me. So I actually took a step back from the research hat that I approached them initially with and found out that really it was more so that Mayo Clinic, the institution that I'm at now, really had not reached out to them before. And when they did, it was more of these hit and run type encounters where they were getting information from them for these research studies and never giving back to them. And it was also a matter of them, you know, also the historical improprieties that we're aware of. So the Tuskegee, the legacy of the Tuskegee syphilis study, as well as Henrietta Lacks. But I would say, although those were also in the conversation, that wasn't the main reason. It was more so we needed to build trust and relationships with the community. So once I did that, you know, my biggest adversaries, I like to say during those times, are now my biggest cheerleaders. And they're the ones that are really, really advocating for their communities to be involved in research, to be a part of this health promotion. And they're actually doing the health promotion themselves now within their churches. And I must say, I didn't mention the name of our organization. So I'm the founding director and principal investigator of the FAITH program. And it's also an acronym similar to CHERISH with Dr. Ferdinand. So it's Fostering African-American Improvement in Total Health, Cardiovascular Health and Wellness Program. And we focus on the development of co-designed, culturally tailored interventions in partnership with the African-American faith community. And we host in-person and digital programming to our communities, as well as emergency preparedness efforts throughout the COVID-19 pandemic. And our project has had significant improvements in cardiovascular health amongst several churches here in Rochester, Minnesota, as well as Minneapolis, St. Paul. And this year marks our 10-year anniversary here in Minnesota. And this weekend, we had a wonderful celebration of events, including attendance by the Minneapolis mayor, who declared Saturday, May 20th, as Faith Health Day. And also the Rochester, Minnesota mayor and St. Paul mayor did so as well. So just bringing back home the point that the Black church or African-American faith community truly has influence. I love that word that the bishop used, the influence of faith leaders to keep this momentum going towards health promotion.
Congratulations on the 10-year anniversary. That's fantastic.
Thank you.
In your opinion, to follow up from that, what else do you think needs to be done? All three of you have been in this space for a really long time. And, you know, having just come off the weekend celebrating the wonderful work that you've done in the past 10 years, what else needs to be done? What would be your main takeaway from all of the work that you've done in the last 10 years on this project?
Well, let me first say that
Go ahead,
I'm very appreciative of the work that the bishop has done and Dr. Brewer has done. We've been doing it probably a little bit longer because I'm a little bit older. We had the Healthy Heart Community Prevention Project since the 1990s, so it's been 3 decades. And my wife is Dr. Daphne Ferdinand. She has a PhD in RN. And we have been one of the pioneers after the lady Elijah Saunders out of Baltimore, going to beauty shops, barbershops, sporting events, churches, parks, community centers, wherever, and doing cardiovascular outreach. So when Tulane got this major multi-million-dollar National Institutes of Health grant for CHERISH, our church-based initiative, I really didn't have much of a barrier. Now, Tulane, you know, I'm from New Orleans. This is the segregated South. And most people who are young can't really wrap their heads around the fact that when I went to school, I didn't go to school with white children. And even Tulane itself was a segregated institution where I'm a professor now. But I had already built up a lot of good faith and good service in my community because I never saw myself as some doctor from the outside. I saw myself as a member of the community, raised and nourished by the teachers and the ministers and the aunties and the aunts and the uncles and the cousins and the people down the street. So it's an extension of my service. It never had anything to do with my selfish drives to get research as a professor. Now, wherever you are, you may not be able to find a concordant physician or a concordant researcher, someone who is from that particular population, but you have to have a community advisory board, or you have to bring into the leadership of whatever research or study or intervention someone from that community so that there can be an ownership that's present in that particular initiative. Our goal is to have 42 churches, randomized cluster design, and in some of the churches do what we usually do screening, lectures, tear out sheets, etc. And then in other churches do an implementation science where we see what works. And what I think we're going to find that works is the self-monitored blood pressure that the bishop spoke to, give the patients valid blood pressure devices, teach patients how to know their medicines, how to challenge their clinicians, whether they be doctors, nurse practitioners, or pharmacists, to do the right thing. Don't have the practitioner say, your blood pressure is a little high today, Ms. Brown, or your sugar's a little high. That type of, I think to some extent, demeaning health encounter is probably where we are today because it's somewhat assumed that Black folks just have worse blood pressure and worse diabetes. I don't think that's inherited. There's no one gene or set of genes that explains these white-Black mortality gaps. So the short answer is, if you can't get somebody who's from the community to be a major part of your intervention, then make sure that you partner with the community to direct these programs and not just think you can fly in because you're Johns Hopkins or Mayo or Tulane and you're going to be successful.
I completely agree with that. That's wonderful.
I agree with that for sure.
And I just wanted to add, I also have that personal connection with, my church growing up. I grew up in the church and just watching my cousins, my aunts and uncles, and even those who were not related to me, they still were family, right? We were all part of the church. Watching some of them die prematurely from hypertension related complications, cardiovascular disease, strokes, heart attacks. That is what truly fueled my passion to combat these health disparities so that my family members and other people that look like me and those that are disadvantaged can live longer and healthier lives. And this is the reason that I do what I do. And it was a natural fit, as Dr. Ferdinand said, that this is really just an extension of my upbringing and my desire to impact the world through service. So
I love that. Thank you both for sharing. Bishop Shanklin, can you please share with your audience some of the work you and your center have done to address community mental health in Maryland? And what are some lessons that can be applied to improving blood pressure or preventing the occurrence of hypertension in the first place?
That's a great question. And I so appreciate, again, what the panelists have shared with how essential just being present, and not only the presence, but ensuring that there are partnerships that are legitimate partnerships who don't just literally just ride in with an effort to rescue, but partnerships who are embedded in the community so that it builds the trust. And a lot of people know that after the pandemic, the next big wave of pandemic issues is that of mental health. And so part of our New Momentum Health and Wellness project is to engage in helping people strengthen their mental health. And so we have a campaign called Your Mental Health is Your Mental Wealth. And so we do know that when the mental health is not in sync and in line, it produces physical consequences and actions related to the stresses on the heart, and things like that. So part of what we've done is we've trained a group of number one, frontline health work, mental health, what we call ambassadors through mental health first aid, where we've trained, at least in our area, over 100 people who know how to recognize frontline those who might be struggling with some mental health challenges. And then from that first frontline, we have created a network to refer people so that they can literally get the help that they need, so that coupled with making sure your heart is right, watch this, not only making sure your heart is right, but making sure your head is right too. So if we can bring head and heart in link and sync with each other, it's just a beauty. It's like literally teaching the head and the heart how to dance together. And so that's, so our program is not only with the mental health first aids, just training people to just recognize, just to demonstrate a high level of empathy and sympathy. And then we have a network where we can refer people to get to that place. And, and I'm a champion for this, because again, there's stigmas associated with the Black and brown and beige community where seeking mental health services was a no-no. So literally, as Dr. Brewer said, we gather as a family and our extended family, and we know that there's some challenges, but people are snickering and just brushing off, but nobody's taking serious that there might be something wrong with our cousin or something wrong with the uncle, as opposed to just pushing it under the rug and pushing it aside. And so we've just found a way to make sure that all of it is connected together, to connect them with doctors who can take care of the physical and connect them with doctors who can take care of the mental and the emotional. And so we've literally got a big old ram's horn, and we've sounded the alarm loudly that, listen, don't just stop at making sure your heart is right. Also make sure your head is right, because if you fix the heart and not the head, your heart is going to go through repetitive dysfunction and irregularity, and you're going to be on this cycle. So let's get off this cycle. So how about this? When you go see your heart doctor, go see your head doctor too. So if you can just balance between the both, man, I can tell you what, as Dr. Brewer said, as Dr. Ferdinand said, you can live a long and healthy life. So, but it has to be both. It can't be either or. It has to be and both. And so those are some of the things that our ministry does, is we promote and work aggressively to take away the stigma for getting mental health services. We take away the stigma. So we offer it on a donation basis. We have lay people that we train, another level above mental health first aid. We have some what we call belief therapist programs. So we just offer just a plethora of resources so that people can know that you can't just focus on one aspect of you and not focus on the other. Let's just make it a team effort. So we can bring that head and heart together. Oh my goodness. You're talking about a smooth ride. That's y'all got me preaching here. That's what happens when you bring a preacher on this panel. The sermon has got to come up at some point or another. So put the head and the heart together. That's sermon number one. Sermon number two, hit H squared. However you do it, start another ministry, do whatever, but get the head right, get the heart right, and we're going to be in business.
I love that so much. Thank you so much. And you're getting applause from the audience. They can't do the actual emoji, but I am getting comments from them. So thank you. It's resonating with them as well. So thank you for that. Dr. Brewer, you wear multiple hats. One of them is a cardiologist in a fairly large health system. How can health systems partner with faith-based organizations to improve hypertension control?
Yeah, so I've been blessed to be a part of, not only receive my training, in an academic medical center, but also to go to work every day at one that truly supports community outreach and also community-based research to better understand what really works within these communities. And I really think that it takes building relationships with surrounding communities that you serve, the patients that you serve from a health system level, and also supporting those like us on the call today and going out to the community and not just, of course, funding works, but also being present. It really does take showing the leadership from these health systems to go out into the community and show that they really care and that this is not just checking the box. And Mayo Clinic has really had a commitment over the past 3 years during the pandemic it's called the Everybody End concept, and it's to end racism with a $100 million commitment to health equity in combating health disparities and racism through anti-racism and diversity, equity, inclusion initiatives throughout Minnesota. And we have been fortunate to be recipients of some of those funds to actually go out into the community to promote heart health, and also, as I mentioned earlier, emergency preparedness. So it does also take them recognizing that there are other influences on your health beyond you just coming to the doctor, right? So I know Dr. Ferdinand had mentioned the social determinants of health as well. So making sure that people have a roof over their head, they have food on the table, that they have a job, that they have these economic opportunities to advance their wealth and their health, right? So it really takes health systems to understand the other influences on health beyond, just coming into the doctor. So I think that's the next step, that we need to really challenge our health systems to get out into the community and address some of these issues beyond just writing a prescription or admitting them to the hospital. Or just, coming to clinic for their annual visit.
I would like.
Yep, I was going to ask you, Dr. Ferdinand. Yep.
Yeah, sure. I would like to say that we've been successful also with academic community partnerships. Tulane University has not only the CHERISH study, which is a major NIH-sponsored trial, but many of the Tulane students and residents have been very supportive of the Healthy Heart Community Prevention Project. Just this fall, we went out to the community centers, we went to churches, we went to wherever and did flu vaccine and COVID-19 vaccine. I consider myself a trusted member of the community, and I'm pleased to have that particular position. It's something that I cherish, and the members of the Tulane academic community support that. The students would come, they would spend time. We even had educational sessions in which they would do handouts, testing, talking about diet, know your medications. So I think more and more of these big academic centers are recognizing just sitting on the hill and waiting for people to come. Yeah, you'll get treatment and it will be evidence-based, guideline-directed medical treatment, but it's not going to change the curve, because the curve of these disparities are based in the social determinants of health, where people work, live, play, and pray. They're based in the community setting. And if we're going to really change these outcomes and not just have big panels at the American Heart Association and the American College of Cardiology describing these disparities, but actually identify and eliminate these disparities, then these community-based interventions is not a side story, it's the story. It's the way we're going to be able to change this. One of the organizations that all of the clinicians on this panel are a member of is the Association of Black Cardiologists. And they've been doing it for years, just like the Healthy Heart Community Prevention Program in New Orleans. And ABC, Association of Black Cardiologists, has a mantra. It's only 5 words. It's one of those like haiku type things. It's real deep. And Bishop, you're going to like this one. 5 words. Children should know their grandparents. Children should know their grandparents. And if you think about those 5 words, I tell it to my patients all the time. I have Clinic Wednesday, I'm going to use it. If you think about those 5 words, it's deep. It means you have to take care of yourself so that your children's children will know who you are and get the benefit of your wisdom, your experience, your life knowledge. And if you don't, you're just going to be that picture on the mantle. They'll say, oh, your grandfather was a great man. He or she was this. Your grandmother, led the community when they did voter registration back in the 60s. They're not going to know you. And children should know your grandparents' thoughts about addressing risk. In other words, knowing the blood pressure, knowing your lipids, knowing your glucose, and having your clinicians do the right thing. Push and motivate your clinicians, not to say, Ms. Brown, your blood pressure's up a little bit, your sugar's a little high. Don't accept that. Know exactly where you're supposed to go with your blood pressure numbers. Be a self-motivated warrior for your own health. Participate in shared decision-making, not where the doctor stands over you and mumbles something and then does an electronic prescription But you ask him, what is the medicine? What is it going to do? What are the side effects? That, I think, is going to be the final pathway to eliminating these disparities. So ICU, great. Bypass, angioplasty, I'm glad that we have it available. Those are wonderful tools that have been given by us, by our creator, in order to make life better for ourselves. But if you're talking about the white, Black mortality gap, shortened life expectancy for Black men and women, we're not going to change it just sitting at these fancy institutions waiting for people to come into the ICU.
Agree.
That is so powerful, and you're getting a lot of messages in the chat for that. So thank you for sharing it. I think, Yvonne, you're back. The fire drill is off.
It was just until like a few seconds ago, and it came back on. I am so sorry, Jenny. I'll have to turn it back to you. Today is just not the day. So
It's okay. We are still very thankful that you're here with us, nevertheless. So I will, Dr. Ferdinand, a lot of our members in the roundtable do represent healthcare systems, large healthcare systems, as well as payers, so insurance companies. What advice would you give our members if they want to reach out, and this is actually to all of you, if they want to reach out to a faith-based organization where they're serving or providing insurance, what is the first step and how do they go about doing that?
I think we need to have community navigators, people who are based in the churches, who can help their members identify where to get adequate insurance. Being uninsured or not having adequate insurance is one of the worst things that you can do in terms of outcomes. Once the person has access, whether it be the Affordable Care Act or whatever's available in the neighborhood, make sure they have an identifiable primary source of care. Having an identifiable primary source of care helps to control those risk factors. Then built on top of making sure there's insurance and having identifiable source of care, have navigators, have people who help get appointments, follow up with appointments, and get medications, and then help them understand why it's necessary to take medicines. Those very simple steps, I think, on the front end, if you don't have insurance, you're not going to be able to stuff enough dollars in your mattress to pay for healthcare in the United States. It's just too expensive. If you don't have an identifiable source of care, even if you have experience, you're going to wait till you have an acute event, meaning chest pain, shortness of breath, swelling, can't urinate. That's too late. And if you then identify conditions, but you don't get medications, you don't adhere, then you're not going to have the control of risk factors. So I think those front end things, ensuring that people have adequate insurance, identifiable source of care, and are able to adhere to their therapies, those are probably as important as anything you're doing. And by the way, just one more comment. I'm a card-carrying cardiologist too, like Dr. Brewer, and I've done all the fancy interventions. So I'm not making anything light about angioplasty, pacemakers, et cetera. But I just look at the burden of disease in the population. In public health interventions, if you wanted to design a tool to change the white-Black mortality gap, it's not going to be we need more angioplasty. And again, I'm not demeaning that as an important intervention for the individual. I'm talking about for the community, the burden of disease across the population.
Great, thank you so much, Dr. Ferdinand. And so I'll throw a question to Dr. Shanklin. So we know that faith leaders serve as gatekeepers, and I love the analogy that Dr. Brewer used in terms of shepherds, in terms of protecting the congregation and making sure that research does not bring harm to the members of the faith-based organization. So my question to you, Bishop Shanklin, and perhaps I'm sure Dr. Brewer and Dr. Ferdinand also have experience with this, is what advice would you have for individuals or organizations who are considering developing these partnerships with faith-based organizations? How do they thoughtfully and intentionally create these sustainable sort of partnerships?
That's a great question. And I would like to, by the powers invested in me, I now license and ordain Dr. Brewer and Dr. Ferdinand. So y'all are pastors and preachers, and so y'all got it from me. I'll send y'all the certificates in the mail when the program is over. But because y'all are on it, I just love it. I think that two things, that if they're going to be thoughtful consideration for this active engagement with the community, what I found is most helpful is passion and partnership. If we don't find people passionate, if we're not, part of what's been my biggest assignment as a faith leader is to generate passion, a passion for health, a passion for wanting to see our community healthy, a passion for wanting to see our community, the mortality rate, expanded, the passion. So I start out, thinking, how do we find passionate people? Because at the end of the day, it can't just be me. I can't carry the burden alone. So I have to find other passionate people who are consistent and considered with regards to being, as Dr. Ferdinand said, is being ambassadors and navigators in our community. So I first look for passion. That's the first thing I do. And if I don't find because here's the thing, if you find somebody without passion, your program is dead on arrival. It's literally not going to go anywhere. So I got to find people with passion. And then once I've sat down and found people with passion, then I look for partnerships. Because for me, it doesn't make any sense to reinvent the wheel. If there are people who are already in the community who are actively doing the things, then literally they become an extension of our ministry. So there are multiple times where we have raised resources within our church community, and we have given checks to partners who are already doing what we already have a passion to do. So I don't have to start another ministry if there is a health organization out in the community that is helping to extend the life and increase mortality among the people in our community. Let's fund them and then use them as an extension, as a tentacle of our ministry so that we have a further reach. So I think that from passion to partnership, if we can get those two things, again, establish those as rail for which the train can move along smoothly, it's literally a game changer. It literally is. And so that passion helps fuel, because now when we go to the partners, they see our passion. And the beauty of that is when we're trying to get funding, we don't want funders to see passionless people. We want funders to see people with passion. So we go in there, we're excited. We're like, hey, we're excited. We're like, Bishop Shanklin, why are you so excited? Because I'm alive, man. What do you mean why I'm excited? I'm alive. This dude got 2 stents and I'm still pumping. I'm doing push-ups, I'm running. So I'm alive. So if I can't be an advocate, then you're not a fund I want to get with anyway. So, but those are 2 things that has helped to continue to stoke and to steer what we effectively do in our community here. That is to find passionate people and then to find those partners that can be married to that. And so we've partnered with our local health department, and we've had an intentional relationship with them for over 10 years, extending. And then our partnership with the American Heart Association. We were one of the award recipients for the faith-based initiative that was competition that was spearheaded by the vice president over our region, and allowing us to extend our reach with regards to mental health. And so we look for those partners. And so the American Heart Association has been one of our biggest partners to get the message out about healthy heart. We participated in healthy eating. I literally transitioned my church from eating after 7, and then we got rid of that fatty food menu. Now you talking about a hated pastor. Be a hated pastor when you remove the fried chicken from the menu. You be hated when you move the collard greens with extra salt. And all of a sudden now, like, Pastor, we boycotting your church. Or boycott you on, but you ain't bringing no fried chicken up in this camp. And so, so we literally helped to change the diet and the mindset of the diet. And why are we eating at 10 o'clock at night? Simply because, well, we be hungry. Well, I'm gonna tell you what you do. Drink water. That'll tide you over. And then if that don't help you, let's engage in a fast and then eat with appropriate time. So even changing diet with regards to heart health, we eliminated every salt shaker in our institution. Our church has not a salt shaker to be found. We don't have no salt shaker in this house. And don't be like those people like to bring their hot sauce with them. You won't bring no salt shaker in here because we have a salt shaker detector. You come through that door, what's wrong? What's wrong? You got salt in your purse. Take that right on back out there, because salt is not allowed, just like you can't smoke. We are smoke-free holy ground, so you can't even smoke in the perimeter of our space and such. So, but that passion and that partnership is what drive some of the deliberate, intentional things that we do to get the message out that we want to, as Dr. Ferdinand said, increase the mortality rate among Black and brown and beige people.
The way I articulate some of those dietary factors, it'll be quick, Dr. Yvonne, is I say that we had survival foods, discarded animal parts, and we had to make them taste good, and we had to add salt so that you could tolerate them. But brothers and sisters, this is 2023. We can do better. And most of the time they'll laugh and chuckle because they know what I mean, living low on the hog and discarded animal parts and trying to make it taste good. But that's okay if that's all you had, but now we can do better.
Yeah, and I wish we could really replicate Dr. Shanklin in every state, county in the country and really spread the word about improving heart health. And Bishop Shanklin, after hearing your story, I can definitely see how much your congregation, and I've seen them watch you, listen to you, learn from you. And so thank you for your leadership. So you talked about passion and partnerships. And there are a lot of passionate people in our communities who want to do the work, but they also need resources, right? So part of our work is also trying to understand what are some policy changes that we need to implement to ensure that faith-based organizations also have the resources they need to help and support more people. So I think this question goes to everyone. And Patty, I see you have a question. We will pose them to our panelists next. So any thoughts on resources that faith-based organizations could benefit from to amplify and extend the work that they're already doing?
So let's stick with hypertension. If you look at hypertension awareness, it is pretty high in the Black community. So I think just checking blood pressure, just screening is not enough. We need to do much more. We fall down when it comes to control. Self-monitored blood pressures where the person has a valid device has been shown to be important, and it's in the guidelines for the initiation of therapy, change of therapy, and for persons who have uncontrolled blood pressure. So loaner services may be very beneficial. We can also seek grants from nonprofits and even profits, local businesses who want to purchase valid blood pressure devices for the congregation. In New Orleans, we had a pilot study called Text My BP NOLA. NOLA stands for New Orleans, Louisiana. We gave devices to 35 patients, 91% of whom are African-American, most were female, most were overweight, 34% had diabetes. And after 8 weeks, the blood pressure dropped about 8 to 10 points. We had higher rates of control, better quality of life. Guess what? I didn't see them. I didn't touch them. It was Bluetooth back to medical students who then text messages to the patients. So that particular clinical linkage was not with the physician, but with another person who did not necessarily have an advanced degree at that time. So I think that's one very practical way. CMS, unfortunately, will not pay for valid blood pressure devices. They got their own reasons. I can't figure it out half the time. But we need to figure out some way of getting patients self-monitored home blood pressure devices.
Yeah, I love that too. As a part of our work, we have also integrated some self-monitoring through those wireless blood pressure monitors. And I think key, and also some of your work too, Yvonne, has involved integrating community health workers into the care team. And I think they could certainly serve as liaisons between these academic medical centers and the churches and the faith community to ensure that not only is blood pressure screened properly, but also treated properly, as Dr. Ferdinand mentioned, and making sure that, it's sustained. So I think really bringing in a community health worker and funding that person and covering, their time and resources as well, and recognizing their value as trusted messengers within the community is also really valuable in the next step that I think that academic medical centers should consider.
And ditto to what they both said, we have, as a ministry, been a recipient of many of the things that have been stated, the grants and the resources that have been getting. And I think that, part of the key to attracting the resources, particularly as a faith-based institution, when you're working from the inside out, the key to attracting the resources is making sure you send the message of inclusivity and not exclusivity. Sometimes funders are very reluctant to fund faith-based because they think you're only going to do it for the church. So what we have found is that the message of inclusivity rings louder to funders and particular, organizations and institutions that want to provide funds when they realize that we're not just going to service a few. When we say we're going to service community, we literally mean we're going to service the community. We are the boots on the ground when it comes to recognizing and being aware of the needs that are happening in our local community, always have been and always will be. So that's one of our main primary messages is, hey, we work on the premise of inclusivity, not exclusivity. We're not excluding anybody. So you may not specifically live in our community, but if you come for them services, you will not be turned away. You will not be turned away, and you'll be invited just like anybody else, because the broader we can cast the net, the more people we can reach, the more people we can save. And that's the ultimate goal.
Great, thank you. And I just wanted to read this comment and question from Hattie. She said, thank you for bringing your passion and talents to the national stage. Amazingly wonderful work you're doing. Couldn't agree more. She asked about some NHCR write-ups or videos from your work. And so if you have any links to some of your articles, please feel free to drop them in the chat so others can benefit from them. But she asked a question, are you aware of research showing the relationship between premature deaths of parents and grandparents from MI, and I believe S is stroke, to poverty of the next generation? So making the link between the deaths of parents and grandparents and how, when we talk about generational wealth, but I think she's alluding to the opposite of that. So if, parents and grandparents die prematurely, what impact does it have on the next generation? And she suggests that it may be a fruitful way to get federal and state dollars devoted to this critical issue. So I don't know if Dr. Brewer or Dr. Ferdinand, you're aware of any research that shows this link.
Absolutely, they're direct links. One of the reasons family history is not in our usual ASCVD risk calculator, because oftentimes it's murky. We don't have enough data. But if the data are available, they're clear is risk clustering around families. There's even risk clustering around neighborhoods. If you go back to the redlining in the 1930s, when they said that certain neighborhoods, especially those with a lot of African Americans or recent immigrants, weren't worthy of getting monies or funds for home ownership, some of those same neighborhoods are suffering from the disparities that we see in cardiovascular disease. So obvious, that is a powerful risk. I always ask patients, mother, father, sister, brother, cousins, because it's a powerful predictor of what's going to happen to that person. And it also brings up that children should know their grandparents' message. They get it because they will say, well, I didn't really know my grandfather. He died at 55.
Yeah, there's a plethora, a wealth of studies showing that if you have poor or less than ideal heart health in younger age, you're more likely to have worse heart health as you age and get older. And there are several studies also showing that the reasons behind that, right? As Dr. Ferdinand mentioned, the redlining, a lot of those social determinants of health, if you look at really detailed in the data, those who were at a disadvantage had lower socioeconomic status, more of a burden of low income, low employment in their neighborhoods, were less likely to have better heart health as they age to adulthood. So this is extremely important that we start early with the younger generation and making sure that they're healthy, because they have to take care of us, right, as they get older.
Yeah, absolutely. So our time is almost up, but I do want to take a moment to thank our panelists, Dr. Brewer, Dr. Ferdinand, and Dr. Shanklin. Thank you for making this hour go by so quickly, but imparting so much wisdom to our audience and sharing your experiences. And for our audience, thank you so much for taking time to join today's Fireside Chat. And I'll turn it over to Jenny, who will wrap things up. Thank you, Jenny.
Thank you all so much. This has been so amazing. I'm so energized having hear you all speak today, and just am so incredibly grateful for the work that you do in your communities and the people that you're serving. So with that, we will be sharing this webinar on our social media platforms. We encourage everyone to share it within their networks and their colleagues. That is a wrap for our Fireside Chat series. We will be back in the fall for our annual summit, and we invite you all to join us then. I hope you have a wonderful summer and you get to have some sunshine and get to spend some quality time with those that you love. So thank you, everyone. Have a wonderful week. Happy Memorial Day. We'll see you later. And thank you to all the panelists. Thank you so much.
Thank you very kindly.
Thank you.
Thank you.